So thank you, Lygia. There were some great foreshadowing comments that you made. My name is Alison Rein. I'm a senior director at Academy Health. I oversee a portfolio of work there that really straddles two major focal areas. One is how we use all of these new sources of data coming from both the healthcare system and outside the healthcare system to generate better evidence. And then also I focus on a lot of work on how to engage patients and consumers more meaningfully in that evidence generation process. So I'm going to be sharing today some insights about some of the ethical, legal, and social dimensions of this brave new consumer e-health world. And want to emphasize up front that I think this is such an important subject, and I'm really gratified to the organizers for inviting me to speak today. But I will tell you, I am not going to be able to do this topic justice in like 15 minutes. It deserves its own couple-day meeting. So it's going to be sort of a whirlwind tour through some of the issues that I hope will be thought-provoking and spark further discussion amongst the roundtable members. So I have a slide, just a little bit of orientation to Academy Health, our mission and vision. In the interest of time, this is all I'm going to say about it, but I'm more than happy to share more about Academy Health and what we do at a later date. I will, however, spend a minute talking about a couple of the programs that we run at Academy Health. And these are just, there's many, many more. These are just some examples of projects that I think resonate particularly with the theme today. So I'm a co-investigator on something called the Electronic Data Methods Forum, or EDM Forum. It was a major infrastructure investment by ARC through the high-tech legislation, American Recovery and Reinvestment Act. And it basically recognizes that with the increased use of electronic health records, there's all these new data, potentially a gold mine of data coming through these systems. But there's some really thorny issues related to methods, governance, data quality, informatics, and then application for a learning healthcare system. And we individually, if we tackle them in one-off silos, it's going to take forever, and we're not going to get to the end game of a learning healthcare system nearly fast enough. So we've created a learning community around this that engages a lot of people who are trying to use electronic health data for the purpose of operations, QI, research, and that covers the full spectrum of research activities. And we use that opportunity to do collaborative work, to share insights, and to work on shared challenges together. Another initiative that we started about 4 years ago is called the Consumer Patient Researcher Roundtable. We call it CPR for short because we like to acronymize everything in Washington. And there again, the real focus is on collaboration. So we have recognized early on in a lot of our project work that very often when we went to meetings, the sort of interests of academics and researchers were presented as polar opposing from the views and interests of patients and consumers, which is actually really odd when you think about it, because I've never read a researcher who says that they were trying to do things to the disadvantage of the patients that they serve, right? And so we started having these conversations and looking for opportunities, particularly in the e-health space, of where we can actually do more work together. So happy to share, again, more about that as well. But again, interest of time. So one of the great things that Lygia did was set me up for this slide, which is basically an acknowledgement that, while there's been a lot of focus on the robust data streams coming out of electronic health records, there's also this explosion of data from other sources, and a whole bunch of other sources, including the devices and the apps and the websites, et cetera, that we've all been talking about. And I think this actually is a really golden opportunity for people where I sit and for the research community and pretty much everybody who cares about health, because finally we can look at data that goes beyond the 10% of health that's represented or attributable to what happens in the care experience, and look at the 90% of health that's affected by everything else. And so I think that's worth keeping in mind as we think about some of these legal and social issues. So again, tremendous opportunities and potential benefits, and I'll just tick through some of those, and I apologize. I always think that animation is going to be like better, and then I realize it's just kind of frustrating. So I'm just going to go ahead and put them all up there, and remind myself for next time not to do that. So here's just a list. It's certainly not the exhaustive list of potential benefits, but these are some potential benefits that at least I've seen through better consumer engagement and technology. And certainly this is a starter set, and in some ensuing slides we'll dig deeper into a subset. But I also wanted to point out that, as Lygia and others have mentioned earlier in the day, there's a tremendous appetite on the part of patients and consumers to actually engage in this space. So these are just some statistics from a recent PricewaterhouseCoopers report, but I should mention that the folks at ONC, the folks at the National Partnership for Women and Families, all in the last year have released survey results that pretty much corroborate and extend some of these findings. So there's tremendous interest and appetite. So all of that said, are there risks? And I've articulated a few up here. And privacy actually is the one that usually gets the most attention. And certainly there's a risk of loss of privacy. And I recently read a paper that sort of distinguished, and I really like this distinction, the risk of personal identification, which is that, I know who you are. So I guess, show of hands, who here has bought a pair of shoes on Zappos and then gone and opened up a totally different website and seen 15 shoes that you looked at? Right, okay, so how do they know, right? It's not the gnome in your living room in your computer. And then there's this blind discrimination, which is what I consider to be sort of discrimination by association, which is, you happen to have a characteristic that's associated with something else, and that may be positive or it may be negative, like a likelihood of prior incarceration or something. There's also loss of control. So, it's arguable at this point to say whether or not we have already lost control of our own data. And there's a slide later on that suggests perhaps we have. But, there's certainly this sense, and Lygia mentioned, that creepy feeling. And the third one here, this diminished access to the potential benefits. So a lot of people have talked about this in terms of the vulnerable populations that you serve or that you interact with. So this is a little bit of the flip side. What happens when they don't get access because they can't purchase the app, or they have to relinquish some level of control in order to gain access to something that they feel they medically need? So these are just some issues, and I think, based on my, albeit limited, thinking that I've done on this topic in preparation for this topic, I think actually that these are not evenly distributed risks. I'm just going to go out on a limb and say that. Okay, so it's been said many times before, but it bears repeating. There is no comprehensive framework for health information, privacy, and security. And I think, what I'm trying to do on this slide is really show that there's all this stuff that's generated by the health system, and I have in here a reminder that that's 10% responsible for your health. And then there's all this other stuff, this explosion, as Lygia said, of other stuff. And that might represent sort of the 90%. And, there are protections, and they go back, and there's sort of social norms, and they go back as far as the Hippocratic Oath. And then you get to, this space, and it's a little bit of Wild West. It's a lot of Wild West. And so there's highly asymmetric knowledge and many points of potential risk. And, I'll acknowledge here that not everybody sort of thinks of risks in the same way. And some people who say, oh, well, that might be a risky behavior, that might be fine with somebody. But we don't necessarily know that at the outset. Let's see. There we go. So this is the slide. This is from LaTanya Sweeney's work, and it's actually already a couple years old, but it basically shows you a map of where, and this is mostly, I believe, the health systems data, generated data. So it's not necessarily acknowledging all of the other data sources that are emerging, and so you can imagine this getting even messier and potentially more confusing and harder to rein in and understand. All right, so I'm going to do a little bit of a wardrobe change now. Not to scare anybody, but that's right. No, hats. So I'm not even wearing a hat. But so I work for a Academy Health, and the things I'm going to say in the ensuing slides are not reflected of my role at Academy Health. They are my own personal opinions. So just wanted to make that perfectly clear. So given all of this, I think the question becomes, what things are health literacy sensitive? That is, if we apply basic health literacy concepts and practices, could we reasonably expect consumers to take some different action? And conversely, are there things that are so complex or so opaque or where there's no transparency that it's just really too much to expect that consumers would be able to sort of engage or interact in that way? So in the next couple slides, I'll walk through some examples, some that I think are potentially health literacy sensitive, and then one that I'm going to posit is probably not so much. And hopefully this will be more food for thought. So the first is consumer use of mobile apps. And so, given the show of hands before and some of the discussion, it sort of comes as no surprise to the folks in this room that when you engage with an app or a device or a website or what have you, they are capturing your data. And they are also capturing the data of all of the other users who happen to use those devices, apps, et cetera. And, in large part, these data are then, aggregated, de-identified, and then used for a variety of purposes. As I think Dean pointed out earlier, you don't really make a lot of money by selling a free app. So what are they using it for? They're using it for advertising, for marketing, et cetera, right? So there's some commodification happening on the back end. And that's important to recognize. So given that, I think there's some design principles, and I harken back to the discussion early this morning. When you're thinking about design from the user experience, there's a whole dimension of health literacy design about data considerations, privacy considerations that I think could be built in. So consistently make terms of use and privacy statements easily accessible, understandable, have the same types of components so that people know what to look for. Share back and contextualize users' data. There's some, really vocal e-patient advocates who are really frustrated by the fact that they can't actually even extract their own data from some of these devices. So, it's not a foregone conclusion. And then also solicit a particularly lower health literacy user feedback in the design process and build in feedback loops, because once you've designed it once doesn't mean that it's always going to be useful in perpetuity. So the next one is consumer participation in something that Lygia mentioned, and that's data donation and also the research process. So I think there's tremendous opportunity and promise and a lot of excitement here, particularly given the recent launch of Apple's Research Kit. But, and in some instances, those doing the research, just to point out, might be HIPAA-covered entities. And in some instances, those doing the research might not be HIPAA-covered entities. So that's actually a first, threshold question, transparency. I think that would be a good sort of health literacy design standard to set. And then wanted to mention, I think everything I said on the app side applies here, plus there's been a lot of work over the last several decades on informed consent and a recognition that a lot of the vehicles we use, a lot of the ways we ask for informed consent aren't really doing justice to the process and not necessarily getting at what we hope for. So we actually, through the EDM Forum, had the opportunity to work with John Wilbanks at Sage. He's developed through that process and with some additional support, basically a set of wireframes and extractable sort of components that anyone who wants to do sort of consent via a mobile device could do. And actually that process and that product is being built in. We don't yet know exactly how much, but got baked into Apple's Research Kit. So basically he's sort of taken the opportunity to say there's an opportunity here with icons coupled with words, coupled with actually doing some testing. So I'm not going to go through the whole thing and then say, do you understand? I'm actually going to incrementally sort of go through a piece of the consent and then test it, and then go to the rest and test it, et cetera. So it just means that there's a much more health literate, intuitive way to go through this process, and I think that's a really important contribution. So put the web link there. And now for the perhaps dodgier area of searching for health-related information on health-related websites. So 70% of U.S. adults look up health information online. This is a Pew study. And then a slightly older study, so maybe the numbers have changed here, and it's not from Pew, is 36%. They know that advertisers are allowed to track their behavior. So that's actually a relatively small subset of those who do it. And then 77% of health searches begin with Google, Bing, or Yahoo. So it's not like they're saying, I'm going to WebMD, or I'm going to Mayo, or I'm going to NIH, or ARC. They're actually going to places that essentially trigger this distinction between a first-party versus a third-party request. So I am not going to do this justice because I don't, there's a whole paper, several papers dedicated to these distinctions. But as I understand it, first party means, I know as the searcher and the host site, CDC, NIH, whatever it is, knows. As soon as that host site has to ping other sites for information and extract that to bring to me, that's when it triggers this third party request. And so basically that means there's little traces of my search and the content of my search that are the terminology is leaked to all of these different third-party sites. And so that information, essentially, researchers have tracked it back and looked and seen that it's largely held by large corporations and data brokers, and then it triggers all of the concerns that we discussed earlier. So, for those reasons, is there a health literacy sensitive solution? In this context, I'm going to say maybe. I would love to hear about one, but probably not, in part because the add-on software solutions are burdensome to end users. Like, there's no way I would figure out how to sort of protect my Macintosh from leaking data. And they also require specialized knowledge and skill. They're only moderately effective, so even when you do it well, you're still having some data leakage. And they're often unavailable even on default browsers. So again, going out on a little bit of a limb and being a little bit provocative, this may be an opportunity where regulatory and/or policy solutions are needed. So, sorry for going a couple minutes over. Thanks for not bringing up the hook. Thank you.